I think really with all the patients, it is not making kind of decision based on a bedside, kind of one-off assessments. I think it's really important to understand that all the people are a heterogeneous group. You get a very fit 85-year-old as opposed to potentially a more frail 65-year-old. So they can present very differently, and age is really just a number. And the need, there's a real need for a more comprehensive assessment. But of course, we acknowledge that not everyone has the luxury of having senior adult oncology services. But we often say that at least some basic identification, such as the frailty screening tools, and also maybe identifying concerns through the holistic needs assessment. We talked a little bit about the crossover between holistic needs assessment and the comprehensive geriatric assessment, for example. And for oncology services to realize that they are not alone with this. I think that, although they are very busy and already overwhelmed with their clinics and having to discuss different cancer treatment options and everything, but there are people around them. So there are frailty teams, they are, in existing hospitals, geriatric services, primary care, community services, and just to kind of to really reach out to these people for help if they notice that there's something not right about the patient, and to also just think about a little bit more about reversibility. So often, we see patients in clinic and we decide whether they're frail or they're not frail, but actually thinking about frailty as a spectrum in older patients, that actually there may be some reversibility and there may be some benefits from prehabilitation, for example.